Assalamu alaikum. Thank you for this nice introduction about me. And actually, I'm very happy today to be with you and to give me the chance to present the local experience of managing lymphoma and myeloma at Prince Mohammed bin Nasser Hospital, Jizan. This is an introduction. As you know, Jizan is located at the south region of the kingdom with more than 2 million citizens and only one hematology oncology center in the city, which is Prince Mohammed bin Nasser Hospital. Previously, patients used to travel outside the city to be treated in the higher centers. We started to treat few number of oncology patients in the beginning, and with time we gained more trust from the patients in our center, and most importantly, we trusted in ourselves to treat those patients. Nowadays, most of the patients with malignant diseases are treated locally. Upfront referral is uncommon. The total number of patients that I'm presenting today is 183 patients, including Hodgkin lymphoma, diffuse large B-cell lymphoma, and multiple myeloma. I believe that the number of patients that we managed and treated in Jizan is much higher, but due to the lack of documentations, and unfortunately some files are missing at the time of this data collections. Starting with lymphoma, this is what we did for newly diagnosed patient with lymphoma. We do the basic labs, as all of you know, and we do bone marrow aspiration and biopsy for all patients to be reviewed locally. And we do echo and band CT for staging. Now for selected patient, we do c-MYC by FISH, plus minus FISH, for BCL2 and BCL6, especially if high c-MYC expression by immune histochemistry. And for some patients, we do PET CT scan before starting chemotherapy. And sometimes we do BFT, and also sometimes we send the slide and blocks for second opinion if the diagnosis is not confirmed. For the follow-up for lymphoma patients at the time of treatment and shortly after treatment for diffuse large B-cell lymphoma, we do interim PET scan after 2 cycles if we plan for 4 cycles of chemotherapy, and we do after 4 cycles if we plan for 6 cycles. And definitely, also, we should do at the end of therapy a PET scan for assessment. For Hodgkin lymphoma, we do interim PET scan after cycle 2B, and if the patient is in molecular remission, then the next PET scan will be at the end of therapy. Otherwise, a repeated PET scan should be done after cycle 4B for assessment. For any lymphoma patient who need radiation therapy or BMT, we send them outside the city for higher centers. And very important point to highlight is that all our lymphoma patients diagnosed after Feb 2022, we give them 2 doses of EvoShield as a COVID-19 prophylaxis. The medications available for lymphoma at Prince Mohammed bin Nasser Hospital include chemotherapy, anti-CD20 monoclonal antibody, anti-CD30, PD-L1 inhibitors, immune-modulating therapy like lenalidomide. We do have also BTK inhibitors and BCL2 inhibitors, venetoclax. The number of patients that I will present today for Hodgkin lymphoma diagnosed and managed from 2015 to 2022 include 63 patients. This is like a summary of how we are treating classic Hodgkin lymphoma at Prince Mohammed bin Nasser Hospital. We divided the patient into limited stage and advanced stage. For limited stage favorable, we give 2 cycles of ABVD plus radiation therapy or 4 cycles of ABVD. We give chemotherapy alone for female and age less than 30. For limited stage unfavorable, we give 4 cycles of ABVD plus radiation therapy or 6 cycles of ABVD. And again, we give chemotherapy alone for female and age less than 30. Any patient with limited stage, either favorable or unfavorable, who is fit to go and to be treated based on the Rathel study, we treated them based on the Rathel study. For advanced stage, we treat the patient based on the Rathel study, followed by radiation therapy to the bulky site. For nodular lymphocyte predominant Hodgkin lymphoma, if the lesion was totally removed at the time of diagnostic investigation, we just observe the patient. Otherwise, we give radiation therapy to patient with limited stage, and we give chemotherapy to patient with advanced stage. This is the sex and age distribution for patient with Hodgkin lymphoma. As you can see in the right side, female 40% and male 60%. And most of our patients, almost 80% of them under the age of 40 at the time of diagnosis as Hodgkin lymphoma. 87% of the patient has classic Hodgkin lymphoma, and 12% of the patient had nodular lymphocyte predominant Hodgkin lymphoma. And for the histological subtype of classic Hodgkin lymphoma, the most common is nodular sclerosis, followed by mixed cellularity type. Almost 50% of the patient, they have a limited stage disease, and 50% of the patient, they have advanced stage disease. The most common chemotherapy given for our patient was ABVD in 82% of the patient. And the second most type of chemotherapy is ABVD plus rituximab. We are giving ABVD plus rituximab for patients with nodular lymphocyte predominant Hodgkin lymphoma with advanced stage disease who need a chemotherapy. But also we do give some patients with classic Hodgkin lymphoma with CD20 positive. Sometimes we are giving them ABVD plus rituximab. This is the response after first-line chemotherapy. At the time of this data analysis, 60% of the patients, they achieve complete remission, and we have another 10% still on active therapy. We have collectively almost 20% of the patient, they achieve only partial remission, or they are refractory to the first-line therapy, or they relapse after achieving the complete remission. And this is for the number of patients that, as I mentioned, they achieve only partial remission or relapse or refractory. Some of them, we send them for radiation therapy, and some of them to higher center for salvage, followed by autologous stem cell transplant. And the percentage of patients among them is 20% who is successfully salvaged and given autologous stem cell transplant. At the time of this data analysis, 80% of the patients with Hodgkin lymphoma is still alive, 80% is still alive, 10% died, and 11% lost follow-up. The estimate overall survival is 63.1 months. The second part of this presentation will be about the high-grade non-Hodgkin lymphoma in Prince Mohammed bin Nasser Hospital, diagnosed and managed between 2015 and 2022. Total number of patients, 78 patients. And this is again how we treat diffuse large B-cell lymphoma at Prince Mohammed bin Nasser Hospital. For patients with age-adjusted IBI of 0, we give them 4 cycles of SHOP plus rituximab, followed by 2 cycles of rituximab based on the FLIER study. For patients with limited stage non-bulky and non-fit for FLIER study, we give them SHOP, rituximab for 3 cycles, followed by radiation therapy, or we give SHOP, rituximab for 6 cycles. Any patient with limited stage bulky or advanced stage, we give them SHOP, rituximab for 6 cycles, plus minus radiation therapy to the initial bulky site. The sex distribution of the patient with high-grade lymphoma, high-grade non-Hodgkin lymphoma in Prince Mohammed bin Nasser Hospital, 46% of the patients are female and 53% of the patients are male, and almost more than 80% of the patients above the age of 50 to 60 at the time of diagnosis. Most of the patients, they have diffuse large B-cell lymphoma. However, we do have other patients with other lymphoma like Burkitt's lymphoma and plasmablastic lymphoma and primary mediastinal B-cell lymphoma. In the left side, as we said, 70 of the patients has diffuse large B-cell lymphoma. The most common subtype is DLBCL NOS. And the most common, the cell of origin was identified in 40% of the patient as germinal B cells, in 10% of the patient as activated B cells, and unfortunately in 40% of the patient we are unable to identify the cell of origin. Stages of the diseases at the time of diagnosis, most of the patient, they have advanced stage disease, more than 60% of the patient. This is the initial chemotherapy given for them. As we said, most of the patients are giving SHOP plus rituximab. However, we do have other patients. We give them mini SHOP because of comorbidities. Some patients will give them only CVB because of underlying cardiac disease. Some patients we give them dose-adjusted EBOC, and we have one patient we give him Codox-M for Burkitt's lymphoma. At the time of this data analysis, 50% of the patients, they achieve complete remission to the first-line therapy, and we have another 10% of the patients still on active therapy at the time of data analysis, and we have collectively 25% of the patients, they achieve only partial remission, or they are refractory to the first-line therapy. For patients, we decided that they need to go for a second-line therapy. We have only 13% of the patient achieve a complete remission too, and we have 13% of the patient still on active therapy at the time of this data analysis. We lost to follow up to 30% of the patient, and 40% of the patient, they did not respond to the second-line therapy. At the time of this data analysis, 62% of the patient is still alive, and 7.7% lost follow-up, and almost 30% of the patient, they died. The cause of death in 70% of the patient was death at home of unknown cause. Some patients, they attended the hospital and they died from septic shock or ischemic heart disease. The estimate overall survival is 56 months. Now going to the last part of this presentation about the multiple myeloma. This is how we investigate our patients with multiple myeloma. We do basic labs and we do beta-2 microglobulin and immunoglobulin quantitation. We do bone marrow aspiration and biopsy for all patients to be reviewed locally. We send FISH, multiple myeloma panel, and SBIB immune fixation and serum free light chain as a send-out lab. We do echo and skeletal survey for all patients. And for selected patients, we do spine and pelvis MRI or whole body MRI. For follow-up, we do SBIB, immune fixation, serum free light chain every 1 to 2 months as a send-out labs. And we do bone marrow biopsy when the patient achieves at least partial remission before sending him for BMT. Any patient who needs BMT or radiation therapy will be sent outside the hospital to higher centers. Now again, I want to highlight this point that all patients with myeloma diagnosed after Feb 2022, we give them 2 doses of EvoShield as a COVID-19 prophylaxis. Medications available for multiple myeloma at Prince Mohammed bin Nasser Hospital. We have chemotherapy, dexamethasone. We have immune-modulating agents like thalidomide, lenalidomide, and pomalidomide. We have proteasome inhibitors, first generation and second generation, and we have monoclonal anti-CD38 antibody. The total number of patients with plasma cell diseases diagnosed and managed from 2015 to 2022 was 42 patients. This is how we treat multiple myeloma at Prince Mohammed bin Nasser Hospital. Simply, we divided them into transplant eligible and ineligible. For patients with transplant eligible, we give them Velcade, lenalidomide, and dexamethasone for 3 to 4 cycles, followed by BMT and then lenalidomide maintenance. And we give Velcade maintenance for patients with high-risk disease. For patient transplant ineligible, again, we give them Velcade, lenalidomide, dexamethasone for 8 to 12 cycles, followed by lenalidomide maintenance for standard risk disease and Velcade maintenance for high-risk disease. The sex distribution of the patient, female 33% and male 66%, and almost 80% of the patient under the age of 75 at the time of diagnosis with multiple myeloma. The most common ISS stage is stage 2, and most of the patients, they have multiple myeloma. However, we do have other patients with free light chain disease, plasma cell leukemia, Waldenström macroglobulinemia, and solitary bone plasmacytoma. Most of the monoclonal immunoglobulin is IgG, and most of the free light chain is CABA. We are able to do FISH testing for 24 patients out of the 42 patients with myeloma. And what we found here is that high-risk cytogenetics was found in 10 out of 24 patients that we did for them FISH, almost in 41% of the patients. The first-line chemotherapy that we give, in 85% of the patient, we give them Velcade, lenalidomide, dexamethasone, or Velcade, cyclophosphamide, dexamethasone. We have some patients, we give them first-line as radiotherapy for solitary bone plasmacytoma, and one patient, we give him dexamethasone, Velcade, and rituximab, followed by rituximab maintenance as a diagnosis of Waldenström macroglobulinemia. We have 9 patients, they achieved good remission and they went for autologous stem cell transplant followed by maintenance. And we have another 6 patients, they went for maintenance without BMT. because they are ineligible for BMT. The second line therapy, we do have, we give Velcade, cyclophosphamide, dexamethasone. Other patients, we give them monoclonal antibodies. We give some patient carfilzomib. This is the response after first line chemotherapy. Collectively, 60 to 70%, they achieve at least partial remission. And we have 11% of the patients, they are refractory to the first line therapy. Fate of patients who achieve, it's not a complete remission, it's a good remission, including partial remission, very good partial remission, and complete remission. The fate of those patients is that 60% of them is still in a good remission. The percentage of patients who successfully proceeded for autologous stem cell transplant is only 20% of the patient. And this is, I think, is a very important point. As I said previously, almost 80% of the patients under the age of 75, and they should go for BMT, but we do have some patients who is ineligible due to comorbidity, some patients ineligible due to nationalities, unfortunately, and some patients, they just want to continue their management locally, and they don't want to go to any place, even for BMT. At the time of this data analysis, 47% of the patients is still alive, and 16.7% lost follow-up, and 35% of the patient died. The cause of death from the congestive heart failure, from COVID-19 infection, and actually we had a very bad experience with multiple myeloma who get COVID-19 infection with a high mortality rate. Some patients, they died from septic shock or cardiogenic shock. The estimate overall survival for all plasma cell diseases in Prince Mohammed bin Nasser Hospital is 53 months. And this is the estimate overall survival by the stage of the disease. As you can see, for the ISS stage 1 is 52 months, for ISS stage 2 is 58 months, and for ISS stage 3 is 45 months. In the last few slides, I will just mention the limitations that we faced at Prince Mohammed bin Nasser Hospital. Unfortunately, we don't have a BMT service. We don't have a radiation oncology. We don't have molecular and cytogenetic. We don't have PET scan. And some patients, they are ineligible to some of the novel medications and new medications, especially for multiple myeloma. What we did to overcome those limitations, we established the send-out labs to Biosentia, Centogene, and sometime to King Faisal Specialist Hospital through the Saudi Diagnostic Lab. We do PET scan and radiation therapy in KFSH Dammam, and we do BMT in a higher centers. This is a special thanks to the team that I'm working with, including all the consultant specialists and residents. And thank you so much.
Well, thank you very much, Dr. Fahad. It's great.